Pharmacologic therapy for diabetes. We talk about three types of diabetes: type 1, type 2, and gestational. So diabetes is a chronic disease of deficient glucose metabolism. Insufficient insulin secretion occurs from beta cells in some instances, and there is impaired insulin use in other instances. Major symptoms include polyuria, polydipsia, and polyphagia, meaning a lot of urine, a lot of drinking of fluid, and a lot of eating. So type 1 is insulin dependent. Type 2 is non-insulin dependent. Gestational diabetes happens during pregnancy. Some patients may develop diabetes after pregnancy, and some develop it in later years. Secondary diabetes can actually happen. It can be drug-induced. So glucocorticoids can cause higher levels of sugar in the blood. Epinephrine can do the same thing, and thiazide diuretics, believe it or not, can also do it. Insulin is released from the beta cells of the islet of Langerhans in the pancreas. It responds to an increase in blood glucose. These little things called insulin go to the cells and act as little keys to open doors on the cells and allow glucose to go into cells. They reduce blood glucose by allowing the glucose to go where it's needed. You will see increased hypoglycemia, so you'll see low blood sugars in people who are taking aspirin, oral anticoagulants, alcohol, oral hypoglycemics, tricyclics, MAOIs, tetracyclines. So less hypoglycemia and possibly higher blood sugars with the thiazides, the glucocorticoids, the oral contraceptives, the thyroid drugs, and with smoking too. Symptoms of hypoglycemia include, but are not limited to, headache, dizziness, confusion, and slurred speech, nervousness, anxiety, agitation, tremors, uncoordinated, sweaty, tachycardic, and seizures. Hyperglycemia has some symptoms. Hyperglycemia has the symptoms of extreme thirst, dry mucous membranes, poor skin turgor, polyuria, fruity breath, fatigue, tachycardia, and possible Kussmaul's respirations. There are different types of insulin. We refer to them as rapid-acting, like Humalog and Novolog, short-acting, like regular, intermediate-acting, like MPH, and long-acting, like Lantus or Levemir. Insulin types. This is where you're going to go through these in class, but I'm going to reiterate them here. Lispro or insulin aspart, Novolog, Humalog, these are rapid acting. The onset of action occurs 5 to 15 minutes. The peak for these is 30 minutes to 1 hour, and the duration can last from 2 to 4 hours. Short-acting insulin is regular insulin, Humulin R, Novolin R, and regular insulin. Onset of action is 30 to 60 minutes, and the peak is 2 to 3 hours. The duration is a little bit variable from person to person. So we look at 3 to 4 hours though. Then we go to the intermediate acting. Now please note that the intermediate acting is the one that you should see that is cloudy. So this is the one that's cloudy. This is normal for the intermediate acting, the insulin isophane, or MPH, Humulin N, Novolin N, N for MPH. This intermediate cloudy one, where cloudy is normal, the onset of action is 2 to 4 hours, the peak is 4 to 12 hours, and the duration is 18 to 24 hours. The long-acting is insulin glargine or Lantus. Onset of action is 1 hour and the duration is 24 hours. Usually it's administered at bedtime. There are some variants of this. Insulin administration, nursing responsibilities. You need to know what their vital signs are. You need to do an assessment, monitor their glucose levels. We shouldn't be giving insulin to people with whom we don't know what their glucose is. Patient-centered care for their adherence at home. Teach administration and how the fingerstick blood glucose works. They should also be taught to use a medic alert and tag bracelet. These are insulin administration sites. There are insulin pen injectors, jet injectors, pumps, and the old-fashioned insulin syringe. Sliding scale insulin is seen here on this screen. You can take a moment to look through this, and you will be seeing these throughout your career. Insulin storage, it should be kept in the fridge. Pull it out 30 minutes before injection, and keep it out of sunlight and or high temperatures. There are many different oral antidiabetics. One group of them is called the sulfonureas. This treats type 2, stimulates beta cells to secrete more insulin. So the names of these can be orinase, tolinase, glucotrol, and glucotrol XL. There are some that are non-sulfonureas. The most famous one is metformin. Decreases hepatic production of glucose following a meal. Lowers serum glucose postprandial. That means after a meal, it lowers that blood glucose. Absorption of glucose from the small intestine is reduced. So our intestine is told, nope, don't take any up. And then it increases insulin receptor sensitivity so that those little keys, the insulin, can fit into those little doors, the receptors, and open up nice and wide and let the sugar into the cells that it should be in, rather than sitting useless in the blood. Alpha-Glucosidase Inhibitors include acarbose, which is, and miglitol. And these inhibit digestive enzyme that would otherwise tell the body to release glucose from complex carbohydrates. Thiazolidinedione Antidiabetics. Avandia and Actose sit under this tongue twister. In these categories with the Avandia, people are at very high risk for MI and contraindicated in CHF. There's a group called the meglitidines. Prandin and Starlix are in these two. It tells beta cells to release insulin. These are short-acting, though. Incretin Modifiers include Januvia and Onglyza. They increase incretin hormones, increase insulin secretion, and decrease glucagon secretion and production. Other antidiabetic agents that don't really sit in any one of these categories include Byetta and Victoza. Type 2 diabetics who can take oral antidiabetics. So if their diabetes mellitus onset is greater than 40 years of age, they've had diabetes less than 5 years, they don't have a severely low BMI, so they're less likely to be a type 1. The fasting fingerstick blood glucose is less than 200, less than 40 units of regular insulin is required for them per day. They also need to have normal kidneys and liver, and this is a big one. When someone has severe hypoglycemia, if they are alert enough, we should be giving them oral sugar. If they are unresponsive, we can give glucagon sub-Q, or we can give D50 IV. There are some hyperglycemic drugs. Dioxazide inhibits insulin release, stimulates release of epinephrine, not given for hypoglycemic ever. It's for hyperinsulinism, and chronic hypoglycemia will ensue from these drugs, so you need to be watching your patient very closely. Another hyperglycemic drug we should really talk about is just insulin itself. So plain old regular insulin. Regular insulin, if someone has diabetic ketoacidosis, regular insulin is given IV. It is the only medication, only insulin that is ever given IV, regular insulin. All right, so that's the biggest hyperglycemic drug. But I'm really happy to see you in class. Thanks for listening, and have a great day.